Thank you, Chairman. I'm really grateful to the Chairman for giving me the opportunity to present at the first international conference of Korean Society for Liver Transplantation. My presentation focused on monitoring high immunological risk and Tacrolimus trough levels in liver transplantation. I understand that this may not be most enjoyable topic during lunch, but I would be grateful if you could listen to it with comfort. We will discuss the importance of the donor-specific antibodies and antibody-mediated rejection, strategies for adequate immune suppression, and practical approaches for clinical practice. By the end, we will understand how to improve outcomes in high-risk liver transplantation patients. Liver is often described as immune suppressive or immune privileged because of its unique properties, which make it more effective in inducing immune tolerance than other organs. Its interaction with immune cells reduces the likelihood of immune rejection. The liver is constantly exposed to various substances, including those from food, the gut, and pathogens. Despite this constant exposure, the liver maintains immune tolerance, preventing unnecessary and potentially harmful immune responses. This is made possible by the liver's special environment, which prioritizes immune regulation over immune activation. The figure outlines the proposed mechanisms of transplantation tolerance in liver transplants. Collectively, all these mechanisms operate in concert to establish and sustain tolerance in liver transplantation, thereby mitigating the risk of graft rejection. While the liver generally poses fewer immunological challenges than other organs, it can still present high immunological risks in certain liver transplantation cases. We will explore the specific scenarios and factors that elevate these risks despite the liver's unique tolerance mechanisms. The high-risk group for liver transplantation includes patients who are more likely to experience rejection due to various factors. Patients at high immunological risk in liver transplantation include those with chronic graft rejection, ABO blood group incompatibility, and autoimmune liver disease. These conditions significantly increase the chances of complications such as graft rejection. Managing immunological risks in transplantation is paramount to prevent various types of rejection, including T cell mediated rejection, antibody mediated rejection, and chronic rejection. Ineffective management of these risks can lead to severe consequences such as cirrhosis, graft loss, and the potential necessity for retransplantation. In liver transplantation, it is vital to maintain the balance between rejection and tolerance. Regulatory T cells play a crucial role in promoting tolerance by helping the body accept the transplanted liver. However, factors such as donor-specific antibodies can disrupt this balance by triggering immune responses that attack the transplanted liver, leading to rejection. Understanding the influence of DSAs on this balance is important for improving transplant outcomes. Let's discuss about concept of DSA. To understand DSA, we need to explore two key concepts. First, HLA, human leukocyte antigens, are molecules on surface of cells that trigger immune responses. Second, non-HLA antigens are other molecules that can also provoke immune reactions. By understanding these concepts, we can better grasp how DSAs form and impact the success of organ transplantation. HLAs encode molecules by major histocompatibility complex on chromosome 6 they play an important role in the immune system by presenting antigens to T cells. There are two main classes of HLA. Class 1, found in all nucleated cells, and class 2, present in antigen-present cells like B cells and macrophages. HLA molecules are highly polymorphic, meaning they vary significantly among individuals. This variation is important in transplantation medicine, as mismatched HLA types can lead to graft rejection. DSAs are antibodies that transplant recipient body creates against the specific HLA antigens of the donor organ. These antibodies can either be preformed, meaning they existed before the transplant, or they can develop de novo after the transplantation. DSAs play a crucial role in determining the risk of graft rejection because they directly target the donor organ, potentially leading to immune responses that can compromise the success of the transplant. Transplant recipients can develop antibodies due to various risk factors such as blood transfusions prior organ transplantation, and pregnancies. For example, platelet transplantation in patients with artificial heart or RBC transfusion in dialysis patients can trigger antibody formation. Patients awaiting retransplantation or those with a history of pregnancy are also at higher risk. On the left, we see how a child inherits different HLA profiles from the mother and father, leading to potential differences in HLA types. These differences can trigger an immune response in the mother during pregnancy. The right side of the figure shows how maternal blood cells process the child's HLA antigens in the lymph node, leading to various immune responses. These include regulatory cells that may help suppress the immune reaction, as well as effector and memory T cells that can contribute to the development of DSAs. This process can have significant implications for future transplants, particularly in increasing the risk of rejection. In 1990s, HLA matching for liver transplants wasn't primary focus. Studies at the time indicated that matching didn't provide significant benefits due to the limited availability of all donor organs and the critical conditions of many recipients. Waiting for perfect match wasn't feasible. Moreover, the liver's ability to tolerate mismatched HLA made matching less of concern, so it wasn't a top priority then. Before 2007, studies on transplant patients with preformed antibodies showed conflicting results on their outcomes. Some suggested poorer result, while others found no significant difference, reflecting the complexity of immune responses in high-risk cases. At the time, there was no clear consensus, posing challenges for clinicians in treatment decisions. Then, what is the clinical significance of DSA now? DSAs, known as donor-specific antibodies, play an important role in antibody-mediated rejection in liver transplantation. When DSAs attach to the donor's HLA antigens on the surface of endothelial cells, they initiate the complement cascade, resulting in the deposition of C4D, a marker of AMR. This activation attracts immune cells like NK cells, macrophages, and neutrophils, which then attack the graft, causing damage to hepatocytes and ultimately leading to graft failure. C4D is a significant marker used to detect the activation of the complement system in AMR. When a recipient antibodies bind to a donor's antigen, this triggers the complement cascade producing C4D. Unlike other components, C4D remains deposited in the tissues, providing a lasting indicator of complement activation. This makes C4D a crucial tool for identifying and diagnosing AMR in liver transplantation, allowing for timely and targeted interventions to protect the graft. The Banff criteria in pathology for liver allografts have evolved significantly since their inception in 1991, originally focusing on kidney transplantations. They were expanded to include liver allografts in 1997, addressing acute and chronic rejection. The criteria were refined in 2000 and underwent further updates until 2019 to improve the diagnosis and management of liver transplant rejection. Here are two cases demonstrating the importance of DSAs in AMR after liver transplantation. The first case showed early pathological findings in ABO incompatible LDLT with positive C4D staining indicating active AMR. The second case highlights late onset AMR in a 1-year-old girl where de novo DSAs developed after the transplant. Both cases emphasize the critical role of DSAs and C4D in diagnosing and managing AMR, stressing the need for post-transplant monitoring. This slide highlights the significant impact of DSAs in subclinical T-cell mediated rejection after LT. This figure shows the increased inflammation and fibrosis observed in DSA positive cases, underscoring the need for monitoring of DSAs. These findings suggest that even in the absence of clinical symptoms, the presence of DSAs can lead to severe graft injury and poor long-term outcomes, emphasizing the importance of early detection and intervention. This study investigates the impact of de novo DSAs on long-term outcomes after LT. Given the growing evidence that de novo DSAs contribute to graft rejection and loss, the authors conducted a systematic review and meta-analysis. They analyzed data from 15 studies involving over more than 2,000 patients to evaluate the correlation between de novo DSAs and post-transplant complications, focusing on identifying de novo DSAs as critical risk factor for adverse outcomes. This figure presents the forest plot showing the association between de novo DSAs and the risk of adverse outcomes after LT. The analysis indicates the patients with de novo DSA have a significantly higher risk, 3.61 times more of experiencing graft loss or rejection compared to those without de novo DSAs. This finding underscores the critical impact of de novo DSAs on long-term transplant success. The study analyzed the impact of de novo DSA on liver transplant outcomes in different patient groups. The results show that de novo DSAs significantly increase the risk of graft rejection, especially in pediatric patients with a tenfold increase compared to adults. LDLT were more negatively affected by de novo DSAs than DDLTs. Furthermore, de novo DSAs were linked to poor outcome regardless of duration of follow-up and the mean fluorescence intensity cutoff values used for detection. These findings highlight the importance of monitoring of de novo DSAs in various transplant situations. Then how can you detect the DSA? Here we explore several methods for detecting de novo DSAs crucial for assessing the risk of rejection in transplant recipients. Techniques like complement-dependent cytotoxicity and AHG-CDC flow cytometry and flow solid phase assays each have unique strength. Understanding these methods is essential for accurately identifying DSAs and managing the immunological risk in transplant patients. Complement-dependent cytotoxicity cross-match test is critical method for detecting DSAs. In this test, the recipient serum is mixed with donor lymphocytes, and if DSAs are present, they will bind to the donor cells and activate the complement system, leading to cell lysis. However, a negative CDC cross-match does not always mean the absence of DSAs, as it can also occur if the donor lymphocytes are not viable or have low antigen expression. This highlights the importance of using additional methods to ensure accurate detection of DSA. Flow cytometric cross-match is a sensitive method for detecting DSA in transplant recipients. In this technique, recipient serum is mixed with donor lymphocytes also. If DSAs are present, they bind to donor cells, forming immune complexes that are detected using flow cytometry by measuring by MFI. This method allows for the detection of both HLA and non-HLA antibodies. This slide gives an overview of a PRA test. The recipient serum is mixed with a panel of donor lymphocytes. If DSAs are present, it leads to cell lysis, resulting in a positive cross-match. On the right side, there are three types of beads screening beads: single antigen beads and recombinant antigen beads. These combined approach in our PRA testing help evaluate the likelihood of transplant rejection and provide guidance for clinical decision making on organ allocation. The PLA single antigen bead assay or flow PRA is a highly sensitive method used to detect and quantify DSAs in transplantation patients. This assay involves mixing the patient's serum with beads coated with single HLA antigens. This method is particularly rarely useful for monitoring changes in antibody levels before and after transplantation, as shown in the graph, helping clinicians tailor immunosuppressive therapies to prevent rejection. This slide explains the principle of a Luminex single antigen bead assay comparing IgG and C1q. C1q is the initial component of complement cascade, which gets activated when an antibody binds to an antigen. So anyway, this slide explains all methods. This slide illustrates the stages of humoral autoimmunity and corresponding DSA detection methods at each stage. The first stage is the latent humoral response, where circulating antibodies are present without causing immediate damage. At this stage, Luminex single antigen bead assay is highly sensitive in detecting these early antibodies. The second stage is silent humoral rejection, where C40 depositions start to occur in the graft tissue, but without obvious sign of rejection. Detection methods such as CDC cross-match, AHG, CDC, and immunohistochemistry through biopsy are crucial to identify the presence of these changes. In the third stage, subclinical humoral rejection, both circulating alloantibodies and C4D deposition are present, leading to tissue injury that is not yet clinically apparent. Flow cytometry and flow solid phase assays are effective in identifying these immune responses and early tissue damage. Finally, the fourth stage, humoral rejection, where significant tissue injury has occurred, leading to graft dysfunction and the transition from acute to chronic rejection. At this stage, all DSA detection methods are employed to monitor the immune response and manage the progression of graft damage. Understanding these stages and using the appropriate detection methods are critical in preventing graft failure and ensuring long-term transplant success. Then how can you use these in clinical practice? We can learn from challenges to HLA-DSA by ABO protocol in Tokyo Women's Medical University. This decision tree outlines the approach to manage cases of positive DSA, the process begins by confirming a, a positive DSA using CDC or flow cytometry matching along with positive bead PRA test. If DSA is positive, the next step is assess the MFI using flow cytometry or Luminex single antigen bead assay. If MFI is greater than 10,000, it is recommended to change the donor due to the high risk of rejection. If MFI is between 1,000 and 10,000, and CDC and C1Q is positive, desensitization and close post-operative immune monitoring are necessary. If MFI is less than 1,000 with negative CDC or C1Q, post-operative immune monitoring is advised. This structured approach helps in making informed decisions to minimize the risk of graft rejection in transplant patients. These radar charts show the MFI of anti-class 2 HLA antibodies before and after treatment with rituximab. On left, before treatment, there is a significant presence of both IgG and C1q binding antibodies, indicating active complement activation and potential for antibodies-mediated rejection. By day 900, post-treatment, as seen on the right, the levels of these antibodies have significantly decreased, demonstrating the effectiveness of rituximab in reducing the immunological risk and improving transplant outcomes. This diagram illustrates various desensitization strategies used to reduce the risk of antibody-mediated rejection in transplantation patients. Key interventions include rituximab, which targets B cells, and bortezomib, which affect the plasma cells. Splenectomy can also reduce antibody production. Plasma exchange can help remove circulating antibodies, while IgG work to neutralize or remove harmful antibodies. Complement inhibitors also prevent the complement cascade, reducing tissue damage. So now talk about the relationship DSA and rejection. Essentially, DSAs are key factors in all these forms of rejection, making their detection and management important in post-transplant care. We explore the importance of treatment for AMR in context of transplantation. First, patients may be presensitized with pre-existing DSAs, which could lead to acute AMR post-transplantation. The goal here is prevention through desensitization strategies aiming to avoid acute rejection. After transplantation, in the acute and chronic phases, new DSAs can develop, leading to further risks of rejection. The key to managing these rejections is timely and effective treatment. So, in summary, by preventing acute AMR and treating rejection episode promptly, we can save both organs and lives. This study focuses on the impact of DSAs in liver transplantation, specifically in the cases of subclinical T-cell mediated rejection. The presence of DSA in subclinical T-cell mediated rejection patients leads to increased inflammation and fibrosis, indicating a higher risk of chronic graft deterioration. Early identification of DSA positive individuals is important for more intensive monitoring and treatment to prevent long-term graft failure. So then how can we use the immunosuppression optimally? The image on the left shows central fibrosis, a key feature of chronic graft injury. The middle panel highlights C4D staining, indicating complement activation linked to DSA. The graph on the right reveals that DSA positive patients are more likely to develop advanced fibrosis stages. The diagram below illustrates how insufficient immunosuppression can lead to DSA formation, C4D deposition, and progressive graft fibrosis. underlining the importance of maintaining adequate immunosuppression levels to protect graft function. This study examines the impact of immunosuppression level on liver allograft fibrosis in pediatric liver transplant recipients. The results show that fibrosis is common, occurring in over 90% of patients, even with normal liver function. The analysis highlighted that maintaining a mean tacrolimus trough concentration of at least 5.1 nanogram per milliliter in the first 1 to 3 years post-transplant significantly reduces the risk of fibrosis. Patients with a low MELD score, those who have undergone previous transplants or are younger than 60 years old, are at increased risk of developing de novo DSAs. Laser immunosuppression, particularly with cyclosporine-based regimen or non-compliant, significantly elevated this risk. Additionally, maintaining tacrolimus level below 5 can double the risk, emphasizing the importance of careful immunosuppressive management. Non-adherence to immunosuppressive therapy is one of the significant factors in chronic graft dysfunction, leading to inconstant immunosuppression and increasing the risk of acute, persistent, or chronic rejection. Maintaining strict adherence to therapy is crucial to prevent these complications and improve long-term graft survival. High tacrolimus intrapatient variability (IPV) has been identified as a significant risk factor for developing de novo DSAs after liver transplantation, as shown in this table. Specifically, patients with coefficients of variability greater than 35% or 40% are at an increased risk, with other ratios indicating a strong association between the high IPV and the occurrence of DSAs. IPV in tacrolimus level is a critical factor to consider in managing immunosuppressive therapy for transplantation patients. IPV can be influenced by several contributing factors, including medication adherence, which is highlighted as the most significant factor. Other factors include drug absorption variability, metabolic differences, drug-drug interactions, and genetic factors. Managing these variables is essential to ensure consistent tacrolimus levels and avoid under-immunosuppression, which could lead to graft rejection. To avoid under-immunosuppression and the development of the de novo DSAs, it is important to maintain a tacrolimus-based immunosuppression regimen. We must avoid very low tacrolimus level, ensure patients adhere strictly to their treatment, and minimize IPV. The goal is maintain tacrolimus level around 5, allowing for controlled minimization to prevent under-immunosuppression, while also avoiding the risk associated with overly high levels. When considering DSA and C4D in liver transplantation, it is important to recognize several limitations. The liver's unique immunological characteristics make interpretation challenging. The non-specific and local deposition of C4D and its sensitivity and specificity issues complicate its use as a reliable marker. Additionally, there is often a discrepancy between DSA and clinical rejection. The varying types and specificity of DSA further add to the complexity. Therefore, it is important to comprehensively evaluate these findings alongside other pathological evidence and clinical symptoms when we diagnose the AMR. So in summary, in managing high-risk transplant patients, it's essential to recognize the presence of DSAs, particularly in those with prior transplants, blood transfusions, or pregnancies. Maintaining tacrolimus levels around 5 is important to avoid under-immunosuppression, while could lead to rejection. Finally, practical recommendations emphasize consistent DSA monitoring and well-structured immunosuppression strategy to ensure successful transplant outcomes. These measures help manage immunological risk effectively, ensuring better long-term result for patients. Thank you for your listening.